So we are continuing our journey into communication, and I'll keep saying it over and over again. Anyone can look up the dose of Saxenda or criteria for bariatric surgery, but communication really is the biggest challenge that primary care providers face when they're dealing with weight management. And that's why we emphasize it so much in this course, not only from the skills standpoint, but from the standpoint of social determinants of health and how that influences the type of communication that we provide. Last week, we talked about core principles, which were outlined in a 2011 scientific statement from the American Heart Association, which I had the privilege of leading. And that's going to be guiding our very prescriptive approach this morning. So after attending the session, you should be able to provide a rationale for why the initial raising of weight in a sensitive way is so critically important. Secondly, summarize the opening the door approach, which we'll talk about in detail, and incorporate appropriate core principles into an opening the door approach. So even though the opening the door approach is very prescriptive, as long as you abide by core principles, you can obviously adopt your own variation of that specific approach. So basically last week we talked about a lot of core principles for communication. We talked first of all about terminology, how we should not use the words obese or fat or heavy in our encounters with patients with obesity. These are considered at some level to be offensive, and even if the patient isn't offended immediately, it often leaves them with a very, very bad feeling once they leave. Empathy, of course, this is an issue. It's a medical issue. It's an interaction of an individual with their environment. We want to be collaborative, never entirely prescriptive. This is what I need you to do. It's more like, well, how do you feel about these goals that we've provided for you? Do you have any ideas that you'd like to share? Allow time. Never discuss weight at the end of an encounter, very, very briefly, with statements such as you need to lose weight and exercise more. I'll see you next month. Hopefully your diabetes will be better. That patients don't like that. And medicalization, which sounds like the absolute wrong thing to do, but you want to stay away from certain sensitive issues. And as I said last week, cosmetic benefits, social benefits of weight loss are really not our concern as healthcare providers. The patients often will bring it up. I'll look better, I'll feel better, I can wear nicer clothes, but don't go there. Talk about some of the health consequences of obesity. So what we're going to do today is talk about an approach that incorporates these core principles. And we want to make sure that we use a sensitive approach after the initial encounter. So remember, even in 2019, about 2/3 of patients have never discussed the issue of weight with their healthcare provider. And so it's an ongoing thing. And it's interesting that 2/3 of American adults are either overweight or have obesity. So interestingly, you're left with that situation of how do I raise this in a sensitive way at the initial encounter with so many patients. Why is it sensitive? Well, there are many fundamental reasons, but two that I want to focus on. First of all, societal expectations. So thinness is expected in society. It carries enormous social value. You only need to watch TV or the movies. You do not see people with obesity. It conveys health, wealth, happiness, all kinds of things, popularity, and especially with young people and especially for women. So that's a sensitive issue. So when you start to say, well, you've got a weight issue, it's like it's sending the message you're not part of all of that success and all of those wonderful things that come with being thin. The second thing is that weight is often a moral judgment. And I may have said this in the first session, that even very young children start to make moral judgments about people with obesity. They are seen as having lack of self-control, lazy, uninterested in health. And therefore, when you discuss this issue with patients, they are actually hearing some of those things about themselves, and they've certainly heard it from other people. It is even more sensitive when you're dealing with childhood and adolescent obesity when you're speaking to a parent, because not only does it indicate some of these moral judgments, it also suggests to the parent that, hey, maybe I'm not such a good parent. Maybe I'm letting my child eat in an uncontrolled way or have an unhealthy lifestyle, and that reflects on my parenting. So imagine how sensitive that is. So here's a corollary that will tell you how sensitive you need to be. If somebody was your adult patient, you would never say something like, do you need an HIV test? Have you been pretty promiscuous? If that's the way you communicate with patients, you've got some serious issues there. You can imagine that the response is not going to be very positive. So if you are initially insensitive, I guarantee you, you will probably close the door permanently. It doesn't mean the patient will walk out or refuse to discuss the issue of weight with you, but they just will not engage in a way that's meaningful. And that's why it's so critically important. So opening the door is a very prescriptive approach. Why? Well, first of all, it's true that I did come up with it. However, it has been adopted by the National Academy of Medicine as part of their core competencies for obesity communication. And it's on page 49, and I'll show you next week just to prove it to you that it's there. And so there is no randomized trial about how one ought to best discuss weight with patients. You can imagine that would not be easy. You don't have the multiple different approaches and compare them. But it was an approach that was adopted over many, many years through consensus, and mostly by what you ought not to do. So this young man has obesity. Yes, he does. But he also is in his high school band. He loves the Chicago Cubs. He has a very supportive family. He's a good student who wants to study computer science. He is so many other things besides a young man with obesity. And you have to keep that in mind as you interact with him. Those are the things that give him joy and pleasure. And yes, this is an issue that you want to tackle with him, but keep in mind that he's a real person. And a prescriptive approach that conveys sensitivity and concern is what we want to use. The other reason a prescriptive approach is what I recommend is because it works. Because over thousands of encounters and trainees who've used it, nobody has been offended that I know of, at least. So here's what we're going to talk about as our initial sample case study. And I'm going to ask a few people to comment. So Viola is a 56-year-old woman, type 2 diabetes, dyslipidemia, hypertension, obstructive sleep apnea. So it's just about everything. Recently diagnosed stable coronary heart disease, all at just 56. She's 5'3" inches tall, weighs 266 pounds. Never has she discussed the issue of weight with any healthcare professional ever. She lives with her husband, who is 58 and also has obesity. So your task is, she's coming to you, I don't know, for what, refills or just a general checkup or request for a mammogram or something that's not related so closely to weight. And I want to ask this question, throw it out to our group this morning. How would you raise the issue initially?
This is Nikki from OSU. I typically will ask someone, how is this weight for them? You know, is this where they have been on average? Have they lost significant weight or gained weight in the last 5 or 10 years? Do they feel comfortable at this weight?
Okay. Thank you, Nikki. And one more.
Hi, this is Christy at Crossroads. The question I often start out with is, I just ask how your weight has been over time. I just say, you're 266 today. How has that been? Is that about the same, or has that changed much over time? And then that often just kind of, that's when patients will open up and kind of tell me what they've been working on and what they think about their weight.
Okay. All right. Thank you, Christy. Okay, so those are all interesting approaches, and let's talk about opening the door and how we might do it. Not that there's no correct or incorrect approach, and some things will work well with patients, and some don't work so well with patients. But here's what I would recommend. So it's very, very prescriptive, and as I said, there's a rationale for it. First of all, it's been adopted into a guideline. Secondly, it works, and nobody seems to object to it. The first thing to do is to express your concern. Viola, I am concerned about your weight, which I think Christy was hinting at in her approach as well. Then you almost don't let them take a breath, right? But you start to medicalize the issue, which was one of our core principles. Your weight puts you at risk for worsening diabetes. Remember, she has diabetes and hypertension, as well as worsening heart disease, period. Then you solicit mutual concern. Is this something that concerns you as well? And finally, a collaborative closing statement. Is this something you would be interested in working on together? So we tried this at Children's Hospital Pittsburgh 13,000 plus times. in all those times, not a single person said, nope, I'm not concerned, have no interest in working on it with you. You have opened the door. It's very, very, very difficult to refuse this request. And if it's difficult to refuse a request, now there is going to be ambivalence, like, oh my gosh, you're talking about my weight, and I just said that I am worried about it, and I'm worried about some of these problems, and I already agreed to work on it with them. They may not express all the enthusiasm you expect, but you've opened the door, which allows you to discuss a number of other things afterwards. That's the advantage of this approach. It incorporates core principles. One is that you are empathetic and concerned. Secondly, that you've medicalized the issue. Third, that you are collaborative. You're soliciting mutual concern as well. Are you worried about this as well? Because if you are, I'd like to work on it with you. It's none of those, you need to go ahead and work on it, or you need to join Weight Watchers, or you need to find some way, or you need to exercise more. I'm going to help you with this. So it is one approach that I think incorporates some of our core principles. There are many variations. Dr. Arya Sharma in Canada has this one. I'm concerned about your weight, again, expressing concern. Do I have your permission to discuss this? So asking permission before you start talking about what are your habits like, or how do you feel about your weight. Adolescents especially sensitive, but this is one that will work for you. So Lauren is an adolescent who's there with her dad. Lauren, I'm concerned about your weight. Would you be interested in working with me and your father to make some changes in your lifestyle over a period of time? You probably don't want to medicalize it too much for someone who's very young and may not understand or relate to diabetes, etc. However, look at the requests that we're making. Are you interested in working with me and your dad, and we'll make some lifestyle changes over a period of time? Very, very hard to say no. And once you've said yes, you can continue in a sensitive way to discuss the issue further. Here's things not to do. Let's talk about your weight. Don't say that. Tell me about your diet. I don't know if you're a patient with obesity, how you would respond to that. Nobody's ever discussed this with you before. What would you say about your diet? You may say it's not very good, or you may be very ambivalent about responding. Do you exercise? Very closed-ended. How do you feel about your weight? Probably not the best approach. It really puts people on the spot. It can be very embarrassing. What if you, because this lady, for example, really can't say I feel okay with it, because she knows that you're asking about weight, and then she knows that you don't think her weight is appropriate. Are you trying to lose weight? Very closed-ended responses that are a little bit judgmental are things to stay away from. Next slide. But what's the worst thing to do? Here is the worst thing to do that happens more often than any other form of communication. So this is a pediatric case, but illustrates it very well. Dawn brings her 9-year-old son, Greg, for a well child check. She's been told by Greg's school nurse that he has obesity. The mom is raising the issue. Doctor, there's been some concern about Greg's weight. And the doctor responds, yeah, BMI percentile is a little high, but he's very active and he'll probably outgrow it. You shouldn't worry. What do you think happens after that? Well, she has now confirmation from her physician that this is not such a big deal, that it's going to get better, that no changes are necessary. And that perpetuates itself year after year after year. It's the easy way out. Yeah, technically you have obesity, but you're on your feet all day at work, which is good. You shouldn't feel bad about your work. You also have a big frame. That should feel bad about your weight. You also have a big frame. So kind of, phrasing it like it's not such a big deal. So this actually happens much more often than the approach that's less sensitive. And you're trying to be sensitive. You're trying to skirt around the issue, maybe because you don't want to deal with it. You don't have time. It's much easier and much more interesting to focus on the consequences of obesity sometimes, or you're afraid of discussing it because even though the patient has raised it, it's a sensitive issue and you don't want to go there necessarily. So this is probably the worst thing of all. So patients who are told that their weight's okay, or it's just not discussed in any meaningful way at this point. So I think we'll stop there and see if we have any questions before we move to our cases.
Hi, this is Paige at Ohio University. I understand, I love this approach, first of all, and I'm just curious, understandably, we're not going to have randomized placebo-controlled trials related to this, but have you gotten any intentional feedback from patients on the approach and how they react to it, and how any suggestions for improvement or that kind of thing?
Yeah, so I mean, these core, first of all, the core principles were decided upon by consensus. The other thing that we did, Paige, is at the NAM, the National Academy of Medicine, the committee actually is made up not just of healthcare professionals and educators and public policy experts, but patients who have obesity. And what we did is we introduced them to different approaches in which weight could be raised. You know, how do you feel about your weight? You know, from things like that to, do you want to lose weight, or let's talk about your weight, to a more collaborative opening the door approach. And we asked them, and there was about 14 or 15 of them there. And these are not your typical patients with obesity. Obviously, they're people who struggle their whole lives, and they are very passionate about the issue. But the opening the door approach was by far the best received of them. So the feedback from patients, adult patients, has been generally positive. The other thing I can tell you, with having worked with residents for a number of years, is when they try this approach, their feedback is generally positive. They haven't had any negative responses to it. So it's perceived to be a very, very sensitive approach in that sense.
Oh, I was just going to say, I would agree, although I think this is such a sensitive area that if we don't ask them, they won't tell us. Because even just like you mentioned, if we ask them how they feel about their weight, they're not going to say they feel great about it. And we're biased. They're not going to say they're not concerned about it either. I would think they'd be embarrassed to say, oh no, this doesn't concern me. So it's good to hear that you've gotten that intentional feedback.
Yeah, absolutely. So yeah, don't embarrass, and don't say anything that might embarrass your patients, but express your concern immediately. First of all, most people with obesity know they have a problem. But when you say, look, I'm concerned about it, and this is why I'm concerned about it for your health. Are you concerned about it? Do you want to work on it together? Just a very quick 4-step approach that kind of makes them feel good in a way. It's like, my doctor's worried about me and he wants to work with me, or she wants to work with me on this issue, rather than, how do you feel about your weight? You should lose weight. You need to exercise more and get on a diet, which is often what patients hear.
You know, I really want to give some props to the clinician, Nikki. You've done a lot with this patient. I mean, you've referred to a dietitian, you've affirmed their weight loss attempts, you've helped her structure a meal plan, and then using her Fitbit to monitor activity, helped her focus on portion sizes, encouraged her to pack her lunch, and meal prep is a huge part sometimes of success in weight loss. And then you've offered to refer to behavioral health for stress management, and then made a referral to bariatric surgery. So you've spent a lot of time with this patient, obviously, and really tried to appropriately address her weight, which is certainly putting her health at risk. So great job with that. So, you know, what I wanted to talk about more today is emotional eating or stress-related eating. And this also, just to kind of foreshadow our next case, boredom is a part of emotional distress, as well as just simply what we call life stress that can lead to excess eating. It's associated with depression. It's also a risk factor for the development of binge eating disorder. But as Dr. Rao said, this patient probably does not have binge eating disorder. There is a neurobiological basis for eating in times of stress, and foods that are high in sugar and fat, they do stimulate the release of dopamine and endogenous opioids that counteract the effects of stress. So this is a real effect. And then carbs specifically lead to release of serotonin, which also helps people feel better. Interestingly, protein intake does not lead to that release. So carbs are really kind of preferred when people are in times of stress. So this relationship can develop then in a very reinforcing way that when people feel stressed, they eat fat and carbs, they feel a little bit better. And so this can become a very, very powerful kind of self-reinforcing mechanism. And they oftentimes learn this early in life. So it becomes a kind of an automatic thing that people go to in times of stress. Later, there may be feelings of shame and guilt about overeating and eating these particular foods that are not in their best interest. But those emotions are separated from the association close association between actually eating and feeling better. So that's kind of where this comes from, at least according to the literature. They believe this is how this relationship really starts. So what is at the core of this appears to be tolerating emotional distress and the inability to tolerate that. But people are oftentimes not really aware that emotional distress is really at the core of it, because it's become an automatic connection between eating and distress. So really what we need to help people do is be able to tolerate feeling emotionally distressed or bored without turning to food. So it's a coping mechanism, and we want to help them get to healthier coping mechanisms. But the first step that's oftentimes very helpful is first helping them come to greater awareness of what is actually going on, that there's this relationship between distress and wanting to avoid that distress, and then turning to foods which help them feel better. So mindfulness techniques have been shown to be very effective, significantly effective in a systematic review, in significantly decreasing emotional eating, although there is mixed evidence for their effectiveness in reducing body weight. But it has been shown to significantly decrease emotional eating. So what this enables people to do is to approach food cravings with kind of a non-judgmental curiosity, which allows them to differentiate real hunger from emotionally driven cravings. And so they can then, they can notice their bodily sensation, their thoughts, their feelings before they immediately turn to food. So they're bringing up from an unconscious reaction to consciousness and being able to reflect on that and observe what's going on inside them. And so this leads to greater awareness of triggers, and then that diffuses them with this non-judgmental attitude towards them. And then they're in a position to seek out healthier coping mechanisms like exercise, social support, breathing and relaxation techniques, to name a few. So mindfulness has really come into the mainstream. And so it's, mindfulness classes are available in many workplaces and community centers and churches. People can learn these techniques through books and videos online. These resources are widely available. So I encourage you, if you have patients who appear to be eating in reaction to distress, and this is very, very common. It's also very common that people will be successful in losing weight, encounter times of stress, and then a lot of that success will be undone. So it's a great way to kind of safeguard against that from happening by helping them come to greater awareness about the role of stress and distress and emotional eating, and be able to be aware of that and develop healthier coping skills to prevent that from happening in the first place.
Thank you, Jim. Any questions for Jim? Chris, would you like to comment?
Sure. And I think the idea of addressing the stress ahead of time is definitely going to be one of those elements. The balance that we have here is that for people, food is more than just nutritional status. It's the comfort piece that goes along with it. It's in some ways here used as a stress management technique. And I think the idea of transitioning to something else and identifying those become very important. So if it's not successful to get on to something else besides food as far as that stress management, I think at the early stage, you're looking at things more like portion size. If you know you're going to go to those foods because they're going to give you those comfort. Don't sit down with the entire bag, sit down with part of it. And then it can help them kind of start working towards that portion size piece. Because with this short period of time, we're getting into a new situation about how much an individual can consume. So after bariatric surgery, the amount they're going to be able to consume is going to be significantly less, which means that planning, that meal planning that they've been doing becomes really important. The ability to plan out what you can eat so you can actually meet your nutritional needs. Because just because you can eat less and eat less calories doesn't mean you also don't have all the other nutritional needs. So just kind of essentially weaning from the comfort foods into other strategies that can be used so that you can optimize that intake to actually meet the nutritional needs, but also to kind of recognize those emotional attachments that people have with food more than just meeting those nutritional needs. So kind of pulling straight away from that may then lead to more stress because the one place they want to reduce their stress now becomes an additional stressor. But kind of thinking about those in that type of a transition, because this is going to be an important aspect with meeting their nutritional needs after bariatric surgery.
Okay, thank you, Chris. So just to echo some of those comments, you know, if this isn't addressed early on, and I'm glad Nikki is addressing it early on, but she has bariatric surgery, and of course you can get sick if you overeat after sleeve gastrectomy. That's one issue, but the other issue is that you can gradually gain weight. So sleeve gastrectomy essentially is reducing the size of the stomach. There's no bypass there. So the stomach can gradually expand over time, and she can gradually gain weight and be back to where she started from 2 or 3 years from now. And so you really haven't achieved a whole lot at that point. You've got to address the stress-related eating early on. The other thing I would say is my whole philosophy when it comes to obesity has been very public health oriented, you know, tackling the soft drink consumption epidemic in our country, and better school lunches and all these sorts of things, with the idea that, you know, across the population, these will have a tremendous impact. And that informs the way we approach goal setting with our patients and say, look, if you eliminate sugar sweetened beverages, if you don't eat at night, if you have breakfast every morning, you will lose weight. But there remains, of course, a significant subset of the population who have obesity, who are following all the basic habits that across the public lead to obesity, but still remain overweight. And in many of those patients, I think stress-related eating, if not binge eating disorder, but definitely stress-related eating, as Chris was suggesting, with very large portions, are contributing to the problem. And that requires a much more individual counseling type approach that Jim described as well. That she'll probably see some improvement in her fasting lipid panel as well. So that's a powerful motivator for people. And I know that both among adults and children, when you can actually show substantial improvement in some biological parameter because of something they've done, that's a fairly impressive outcome. The other thing I would say is that a woman of this age, and perhaps Chris would know more than I do, but a woman of that age has very low resting energy and expenditure. And really, if she wants to prevent diabetes, she needs to reduce her waist circumference and to be engaged in some sort of physical activity on a regular basis, meaning daily. If she can use a recumbent bike 30 minutes a day, going at a moderate pace, that will at least make it less likely that she'll get it. But it's remarkable how little someone like that really needs to eat to maintain a healthy weight at that age, and with her lifestyle, it's not a whole lot. So perhaps Dr. Joyce has a question. Insurance will not cover an A1C every 2 months, every 3 is most often here. For most insurances, actually, if you look at an EMR on Medicare, sometimes if you're making adjustments to therapy, they will allow you to go down to once a month. They'll say, have you had this in the last month? That having been said, if you have the point of care machine, I don't know how much the cartridges are. I think they're about $15 to $20, which is not a huge amount. And I'm not sure what your practice environment is like. So it's wonderful when you can bill for it. If you can't bill for it, it's not a huge cost. So Chris, do you have any suggestions for her?
Do we know anything? Is she one of those individuals who likes to cook, or what is her kind of food situation, out of curiosity?
So she, because she lives alone, she doesn't like to cook often. I'm trying to get her to look at cooking a couple times a week and using the leftovers for lunch. But that is something it's a great point I need to work on with her. She does eat 3 meals a day though, and she doesn't skip breakfast. But she doesn't love to cook, so I'm going to try and use that leftover strategy with her.
Yeah, because with her living next door to her daughter now in the duplex, we have a tendency to see where the older generation actually tends to eat a little bit better diet quality, because they tend to come from more of the background of, cooking and 3 square meals and that sort of thing. So we tend to be working off a slightly better kind of mindset around what the food patterns might be. So the ability to cook and even be able to freeze some, it might also give her some of those things to address boredom and things like that. It gives her an ability to kind of do some prepping and things to kind of get up and move around a little. And with her daughter there, may also then help with the maternal instincts about then having a meal together with her daughter and things like that, or even the ability, she wants to walk with her sister, being able to walk with her daughter, that would help her get out and around some as well, to be able to utilize that. Because I'm assuming they're close enough that if she's willing to live next door, there's a bit of a relationship piece there that would help be able to get some of the physical activity and maybe some of the eating patterns to carry forward. And then with that lower energy need, essentially, the ability for just regular physical activity to kind of be that back door to clear the glucose besides insulin should help with the weight management aspect, but it should also help her get the A1C down much more quickly. Just the fact of walking on a regular basis, it doesn't have to be excessive energy expenditure, but the ability just to walk, to maintain that mobility and flexibility, that will help with fall reduction for later in life, but then also bringing down those glucose levels and helping with hypertension. And I know there are other programs through the Y. So if she's already given interest in that, then it might help with some of the social situations. She's moved here from this other area, so it gives her an ability to find some other people and provide that network, so you won't have to be as much of a how do I get her to come back, if you can help build some of that support structure that'll help keep her motivated.
Thank you, Chris. I'm going to try to address a couple of questions quickly and then turn things over to Jim, who can maybe talk a little bit about boredom-related eating. But Sherry has a question. With knee pain, you usually recommend water exercise, but harder for some folks to do that. Exactly my experience. Have you found bike to worsen or help with knee pain? What exercise would you recommend? So first of all, it's kind of our instinct. We have an older person, an older woman in particular, who has obesity, and we say you need to lose weight, you'll improve your diabetes, you should do water aerobics. Well, that's not for everybody. First of all, you can imagine the reasons are complex. People often don't like that from a social standpoint. I know that I'm part of a study that's based in Chicago with older women with diabetes, and they don't want to do water aerobics. What we do recommend is exactly what Chris just said, is just go for a walk, and rather than going at a brisk pace or getting out of breath, just go slowly, but make sure it is sustained, which by itself will improve hypertension and also increase insulin sensitivity and prevent her from getting the outcome that she's so concerned about. So even though it's an easy suggestion, and some people would love it, I don't know how much movement takes place with water exercise in someone that age with knee pain. And secondly, she may not, it might not be socially something that she finds acceptable. Question from Crossroads, will we be discussing intermittent fasting? We certainly can. I think we talked about the keto diet a couple of weeks ago, so we could certainly do that. Just I don't think we'll have time today. There's been quite a bit written about it recently, so we can spend a significant amount of time on that as well. Looks like she's having knee replacement surgery. Jim, do you want to wrap us, take us to the end here with just a couple of comments about boredom?
Sure.
Because that seems to be a challenge for her.
Yeah, so boredom is another form of emotional distress that can lead to emotional eating. And so, you know, what with this woman being a little bit older, I don't know how open she is to, as I mentioned, mindfulness can really help a great deal. It's been shown scientifically to be very effective for emotional eating. If at the YMCA or a senior center, she may be able to get some training in mindfulness and some help with that. If not, you know, it's also not too difficult to just simply explore that with her. You know, you've mentioned that you tend to eat when you're bored. Can you tell me a little bit more about that, when that happens? And help her kind of unpack the chronology of events, what happens when she gets bored, and then how that might lead to eating. And that can help her see, as she describes that there's a connection between boredom and eating and what that's about and what those feelings are, those feelings of boredom, and how that can be distressful and lead to this eating. And as you're going into winter, as you mentioned, you're a little concerned about inactivity. You know, are there ways that she can fill up her life more with meaningful activities that give her a real purpose every day, in addition to spending time with her daughter? And her daughter may work, and so there may be many hours during the day when she's not around. But are there social activities, developing her social network more fully, engaging in activities and things with other people that make her day full and minimize the amount of boredom and the amount of time she has to get bored, you know, to reduce those times when she may be eating. But mindfulness and developing other coping mechanisms, one of those being, of course, social support, as I'm mentioning here, can be really helpful too. So you can do that yourself as a dietitian or a nurse practitioner, or you can refer her to get some help with mindfulness. But you can certainly help her plan and develop other coping mechanisms that could be really helpful.
Okay, thanks to Total Health and Wellness for both of the cases today. Very, very interesting and very timely as well. I'm going to turn things back to Shannon for a moment.
Okay, we wanted to point out that all of our echo clinics are on our website, cardio.org. You will have to register to use them. So please go ahead and click on the link here. It was in your slides that I sent out. You can register, and then you will be able to view if you missed any sessions, or if you wanted to review some additional principles, you could go ahead and review those. Next slide, and you will be able to receive CME credits if you wish to do so for your attendance today. And you should receive a survey in your inbox, and it's available until 5 p.m. tomorrow. If you would please complete the survey about today's clinic, we would appreciate that for our evaluation purposes. Next week, we have communication principles of motivational interviewing, and we'll see you on the 10th. Have a good day, everyone.